Hello, my name is Nikita Ivanov. I'm a nurse practitioner at PC Cancer, and I mainly work with the prostate cancer patients. I also run a clinic on androgen deprivation therapy and managing the side effects of the androgen deprivation therapy. And I also run an education session on management of metastatic prostate cancer. And that's what we're here today to discuss management of metastatic prostate cancer. Just a short thank you to our sponsors who made this program possible. So Prostate Cancer Support Care program consists of 7 modules, and today specifically we're talking about metastatic prostate cancer, module number 7, but I always recommend all my patients and clients to attend other modules, and specifically modules on exercise and diet. In the session today, we will learn about prostate cancer and specifically disease states, the terms castration or hormone sensitive and castration resistant. We understand the disease characteristics and natural history of metastatic prostate cancer. We'll become familiar with different treatments for metastatic prostate cancer, specific medications and the side effects, and we will learn how to prepare for the treatment. So prostate cancer disease states. There are 2 main states of prostate cancer, hormone sensitive and castration resistant. In a nutshell, hormone sensitive is when we treat patients with androgen deprivation therapy, low patients' testosterone who has a prostate cancer, the testosterone goes to 0 and the PSA will go down. So it might go to 0 as well, and the cancer will stabilize, so it won't progress. For castration-resistant disease is a second stage of the prostate cancer where androgen deprivation therapy alone doesn't work. So we'll need to add additional medications to androgen deprivation therapy to suppress growth of the prostate cancer. Those stages are also divided into substages. So hormone sensitive can be non-metastatic. So it can be newly diagnosed patients. And this is the patients that it's usually seen in urologist's office. There are about 80% of patients diagnosed with a localized disease only. It means that the prostate cancer is only in the prostate. And they will undergo local treatment, be it radiation therapy or surgery. It also can be biochemical relapse. So the patient underwent initial treatment either with surgery and radiation, but unfortunately the PSA started to rise again. Another stage is metastatic. Again, the patient might have already had either surgery or radiation, and they progressed and they developed metastasis. It means that the prostate cancer spread outside of the prostate, even prior to the surgery, but it took some time for the prostate cancer to grow and start producing PSA, and metastasis become visible on imaging, and we call the state recurrent. About 20% of patients, unfortunately, come already with metastatic hormone-sensitive prostate cancer. It means that besides cancer in the prostate, they have prostate cancer in other parts of their body, and they call these patients de novo metastatic prostate cancer. So castration-resistant prostate cancer also divided in 2 stages, non-metastatic, and there are about only 10% of patients who usually we see in practice who develop castration-resistant disease but still don't have any metastasis visible on imaging. Majority of patients, once they progress to the castration-resistant disease, will develop metastasis. Today, specifically in this session, we will cover the management of hormone-sensitive metastatic disease and castration-resistant metastatic prostate cancer. So how do we determine if the patient actually has metastasis? We use 2 imaging modalities, CT scan, and we look at usually at the chest, abdomen, and pelvis, and we look the progression of the prostate cancer or metastasis of prostate cancer into the soft tissues. It could be lungs, it could be liver, it could be lymph nodes. And we also would be able to see bone metastasis on CT scans. We also use bone scan, which specifically looks at the spread of the prostate cancer in the bones and is more sensitive in determining if the patient has metastasis in the bones. You might have already heard about new imaging modalities called PSMA PET scan. And on the right, you can see the pictures. At the bottom, there is a CT scan, which points to the small, tiny nodule. And usually this nodule would be considered to be a normal part of the body. So any nodule which is less than 1 centimeter is considered to be normal. However, when we overlay PSMA imaging, we see that this nodule actually harbor prostate cells, which shouldn't be there. So this is actually is a metastasis. So PSMA scan is probably will be the standard of therapy in the future. Currently, we only have PSMA PET scan here in British Columbia as part of the clinical trial. Hopefully, in about 2 years, it will be available for the broader population. Currently, the wait for the PSMA PET scan is about 6 months. Also, most of the clinical trials that were done on prostate with prostate cancer patients. Those trials were done with CT scan and bone scan. So we still based most of our decision and rely on CT scan and bone scan. So where metastasis usually spread? So most commonly metastasis would spread into the axial skeleton. So it would be spine and pelvis. It also can spread into the long bones of their arms and legs, and it will and it's usually spreads to the pelvic lymph nodes. Less commonly, we will see metastasis spread, at least initially, into the soft organs, be it lung or the liver. And in my practice, I think over the past 6 years, I only saw 2 patients who had metastasis in the brain. So very rarely prostate cancer would spread into the brain. So if we do see metastasis initially spread into the soft organs, usually it means that disease is a little more aggressive for those patients, and outcome for these patients is not as good as for the patients, for example, who had spread of metastasis only into the bones or lymph nodes. Androgen deprivation therapy, I would hope that by now you might be familiar with androgen deprivation therapy, but there is a little reminder. So androgen deprivation therapy is a backbone therapy for metastatic prostate cancer. So why we use it is how it works. It's we reduce testosterone level by suppressing testosterone production from testes. And testosterone, in a nutshell, serves as food for the prostate cancer cells. So by essentially starving prostate cancer, we will kill some of the cells, prostate cancer cells. But unfortunately, we know that once the prostate cancer become metastatic, and some of the cells will not die, they will become dormant. Androgen deprivation therapy will be backbone therapy for the entire course of the disease for patients with metastatic prostate cancer, and all other medications, be it targeted hormonal therapy, radium-223, or chemotherapy, will be added on androgen deprivation therapy. There are multiple side effects from androgen deprivation therapy, and again, all of those side effects are results of the low testosterone levels, and it can be loss of sex drive, erectile dysfunction, hot flashes, insomnia, depression, memory issues, brain fog, increased cardiovascular risks, metabolic syndrome. It's increased in blood pressure, increase in bad fats circulating in the blood, blood. So if you're interested to learn more about androgen deprivation therapy, I would recommend attending a module 4, which specifically talks about androgen deprivation therapy side effects and how to manage those side effects. On this slide, we can see the course of prostate cancer progression through different stages and the medications that we use at different stages. And why is it important to understand at what stage the patient is because there are different medications available for treatment of this particular stage. Also, the sequencing is very important because if the patient's been treated with some medications in the earlier stage, they might not be eligible to receive medications at a later stage. And because again, we're in a public health system and there is only certain medications are approved to be used in sequence. So there are a lot of decision goes into what specific treatment we select for our patients. And in a nutshell, we're looking how looking at the volume of the disease. Is the disease volumes high or low? And we'll talk later about what it actually means. When we consider treatment for the patient, we'll consider several things. We'll consider the volume of disease, how aggressive the disease is, how fast the cancer is spreading, what other comorbidities or medical condition patient might have, prior therapies for the prostate cancer. That's where the sequencing of the medications is very important. Toxicities of the therapies, duration of the therapies. For example, some therapies can be given for 6 months. Other therapies will have to be taken for lifetime or till the patient progresses. And of course, patient's preferences and logistics. Is, for example, if the patient likes to travel or they actually can't come to the clinic on a regular basis. So all of this is a conversation between a patient and the healthcare provider, and the decision, again, there is a lot of consideration is taken into making the decision which medication to choose. So I mentioned before, when the patient comes in with a metastatic hormone sensitive stage, we look at whether the patient has a high or low volume disease. So if the patient has 3 or more bone metastases with 1 metastasis outside of the axial skeleton, so be it in the ribs or long bones of the arms or legs, and or if the patient has even 1 metastasis in this soft in the organs, be it liver or lung, or if their Gleason score more than 8. So if we put the prostate cancer cells under the microscope and we assign a Gleason score, which means it's the more different prostate cancer cell from original prostate cell, the high is the Gleason score. And low volume disease is everything but high volume disease. So what are the treatment options that are available here in British Columbia for the patients who have high volume disease? Again, backbone therapy is always going to be androgen deprivation therapy. So we could offer patients chemotherapy, which is called docetaxel chemotherapy, or we can offer hormonal agents such as abiraterone or apalutamide. For the low volume disease patients, we don't offer chemotherapy, and especially in nowadays over COVID-19, we prefer not to offer therapy which lowers immune system, and docetaxel chemotherapy does lower immune system. So for the low volume disease, we'll offer abiraterone, apalutamide. Also, we can have a discussion with the patients. As I said, androgen deprivation, although this also for the low volume disease patients, so we could have a discussion of androgen deprivation therapy alone or intermittent androgen deprivation therapy. It means that we will give androgen deprivation therapy for an average of 9 months. And then if the PSA went down, then we'll stop the therapy and we will let testosterone come up. We'll let PSA come up as well to a certain level, and we'll reinitiate the therapy again. Why we do it? Although majority of the medications is relatively well tolerated, but all of them do have side effects. So again, we will have a discussion with the patients, what's their preference and how, and we'll look how those treatments would impact patients' quality of life. So on this slide, we can see all the treatments that are currently available in British Columbia. So the first group of medications that we have are docetaxel and cabazitaxel. So docetaxel chemotherapy is given with corticosteroids, either dexamethasone or prednisone. It is given intravenously. It is given every 3 weeks. And it's depending on what stage the patient is in castration-sensitive disease, we'll give it for 6 cycles. In castration-resistant disease, we'll give it up to 10 cycles. It does cause fatigue. It does lead to a lower blood count, specifically in white blood cells, which fight infections. And that's why we tell patients, if they feel that they have some signs and symptoms of infection, they should contact us right away, because the infection can spread really fast. It can affect patient's gut. It can lead to the diarrhea. It can lead to neuropathies, meaning that the patients might experience numbness and tingling in their feet and fingers, and patients will start losing their hair 2 weeks into the therapy. So another chemotherapy that we offer, and it's been recently approved in British Columbia, and by recently I mean it was approved only in August 2020. It is also given intravenously. It's given every 3 weeks, up to 10 cycles, only in castration-resistant stage, and only if patients had prior docetaxel chemotherapy. It has very similar side effect profile to the docetaxel, but it's tolerated a little bit easier than docetaxel chemotherapy, and it does not lead to the hair loss. Another group of drugs is oral hormonal therapy, and we can think of it as a targeted therapy. And we have medications such as enzalutamide, apalutamide, and abiraterone. And very soon we'll have another medication coming specifically for non-metastatic castration-resistant cancer called darolutamide. So enzalutamide is a medication which is taken orally at 4 pills, total dose of 160 milligrams. The main side effects that impacts patients' quality of life is usually fatigue. It can also cause high blood pressure. It can also cause some tingling and numbness in patients' feet. It also lowers seizure threshold, meaning the patients who have had previous seizures, epilepsy, stroke, they potentially could develop seizures on enzalutamide. So we don't use this medication in patients who previously had either seizures, epilepsy, or recent stroke. So in my practice, I haven't had a single patient who had a seizure on the enzalutamide. Another medication, apalutamide. Again, it's an oral medication, 4 pills. It's the total dose of 240 milligrams. The side effects from this medication could be a rash, and the rash sometimes can cover the whole body. We usually will stop the medication, let the rash settle, and restart medication at a low dose initially, and usually the rash won't reappear. It also can cause low thyroid function, so we'll be testing patients' thyroid function while they're on apalutamide, and it can also cause higher blood pressure. So the last medication we currently use is abiraterone. It has to be taken with corticosteroid, which is either could be prednisone or dexamethasone. It can be 4 pills or 2 pills. Again, if the patient has trouble swallowing, we will prescribe 4 pills, which are a little bit smaller. The total dose is 1 gram. This medication has to be taken on empty stomach, while other medication can be taken at any point of time, as long as it's taken every 24 hours. It can cause high blood pressure. It can impact electrolytes such as potassium. It can cause low potassium. It is metabolized by the liver, so it can cause abnormalities in liver function, and it could impact heart function or cardiovascular system. It doesn't have direct toxicity on the heart, but because it causes high blood pressure, water retention, meaning it can cause swelling in the legs, and it could impact cardiovascular system and put additional pressure on the heart. So a patient who has a heart failure or recent heart attack or myocardial infarction, we usually don't prescribe an abiraterone. We will tend to prescribe enzalutamide or apalutamide. Also, because it impacts liver function and electrolytes, potassium, we do test patients' blood every 2 weeks for the period of 3 months. And these medications are taken either for life or until progression. The last group of the medications, or rather medication, is radium-223, and it can be termed as intravenous radiation. So it's a radioactive particle which is given intravenously every 4 weeks. On average, again, duration of this therapy is 5.5 months. It's really well tolerated, but this treatment is specific for patients who have metastatic castration disease and who only have metastasis in their bones. So it doesn't target or kill cancer or suppress cancer in the lymph nodes or organs. Because again, it goes into the bones, it has a potential to suppress bone marrow, so it could cause a low red blood cell count, as well as platelets. And because it's secreted through the gut, it also could cause diarrhea. But as I said, it's relatively well tolerated. And we use this medication in patients with a castration-resistant metastatic prostate cancer. So what should you ask your medical oncology team when you're about to start a new medication? Make sure that you know what options are available to you and why your team prefers one treatment over another. Understand what type of side effects you could expect from this medication, understand how frequently the treatment is given and for how long you will be taking this treatment. And also, again, I would like to make sure that all additional treatments are going to be given on top of the androgen deprivation therapy, because unfortunately we do sometimes have patients who stop the androgen deprivation therapy treatment. We will give them medication, and we're surprised that the PSA continues to go up, and we'll find out by testing their testosterone that their testosterone went down because they stopped androgen deprivation therapy. So also ask how to treat or manage the side effects of the treatment proactively. So be familiar with all the side effects, and that's why I offer patients handout or written material every time I start them on new medication. So all these materials are available on the BC Cancer website, and they're available to you as well. But I would recommend to ask your medical oncology team to provide this information while you're in the office, and you would be able to ask questions about those side effects. And of course, ask whom you could contact if you develop any significant side effects from the therapy or you start feeling unwell. Again, the nursing helpline is available 24/7. So become familiar with the numbers and how the phone numbers and how you can contact BC Cancer in case you need to. So all the treatments that we discussed will improve your survival. They all suppress prostate cancer, and patients do have a better quality of life on those medications, and even on the chemotherapy. I know that a lot of patients are concerned about when they hear the word chemotherapy, how the quality of life would be affected. But I see patients time and time again who were concerned about receiving chemotherapy, and then they tell me that they're surprised they have no side effects, or they tolerate side effects really well, or in fact they feel better on the chemotherapy because they were feeling unwell due to the disease progression. And again, majority of the treatments will lower the PSA as well. And I know how important to patients the PSA levels are, and that it's really easy to understand and track the PSA trajectory as well. And you and your medical provider will decide on the best possible treatment. And we're here at Prostate Cancer Support Care program to support you. Here is some contact information, how you could contact us if you have any questions about this module or would like to sign up for other modules. And thank you.